Hello, my name is Jorge Castillo, and I'm the clinical director of the Bing Center for Waldenstrom's macroglobulinemia at the Dana-Farber Cancer Institute here in Boston. And today we're going to be talking about Waldenstrom's macroglobulinemia. I'm going to give you an update in terms of how I manage my practice, in terms of the diagnosis, the monitoring of these patients, and the treatment options, as well as clinical trials that are going to be very exciting in the near future. As I do with all my presentations, my email address is down there on the bottom. Please feel free to reach out to me if you would like to share, a case, or you would like to, like the slides. Feel free to reach out to me. I'll be happy to be of help. Good. So we will then proceed with my disclosure. So I'm going to leave these conflicts of interest there for a few seconds. And let's start with the first point. I mean, when a patient comes to see me in clinic, one of the first aspects of the care of a patient with Waldenstrom's is to establish the diagnosis of Waldenstrom's. And sometimes this could be challenging because the diagnosis is rare and some patients have some specific clinical features that are a little confusing. I want to remind everybody here that the diagnosis of Waldenstrom's is clinical pathological. It's a combination of clinical features as well as pathological features. Here I have a list of the variables that I feel increase the likelihood that I'm in front of a patient with Waldenstrom's, and it's a combination of the presence of a serum IgM monoclonal paraprotein detected usually through electrophoresis and immunofixation. The second one will be to proceed and doing a bone marrow biopsy, and that should show an excess of lymphoplasmacytic cells consistent with a lymphoplasmacytic lymphoma. And finally, we routinely are now testing for the presence of these somatic mutation in MYD88, specifically L2C5P. Nowadays, we have probes for PCR as well as most NGS platforms include the testing for this mutation. Now, I want to be clear that none of these features alone is diagnostic of Waldenstrom's. For example, patients with IgM MGUS or IgM myeloma can have an IgM paraprotein. Patients with IgM myeloma can have a lymphoplasmacytic lymphoma or lymphoplasmacytic appearance in the marrow. And there are conditions like chronic lymphocytic leukemia, marginal zone lymphoma that can also carry mutations in YD88. So isolated, these features are not diagnostic of Waldenstrom's. But if somebody comes in my clinic with these three at the same time, I think the likelihood they have Waldenstrom's is very high. Once we understand a little bit more the mutations that we see in patients with Waldenstrom's, these mutations in MYD88, which were initially reported in patients with diffuse large B-cell lymphoma, these mutations can be seen in over 90% of the patients with Waldenstrom's. On the right, we have a table of the different studies from the different countries, including Asia, Europe, United States, as well as Latin America, and the different methods that were used for detection of these mutations that can give us an idea of really how high of a prevalence these mutations do have, ranging anywhere between 80% and 100%, depending on the series. Now, most of the mutations are located in 265, and this is what most of us know, in the PCR and the NGS platforms detect these mutations. But there's a small proportion of patients who have mutations outside of 265, and could be in 219, 243, or 232, as you can see in the graph. But this is a minority. I would say probably about 2% of the mutations are not in 265. A second series of mutations that we see in patients with Waldenstrom's is mutations in CXCR4. And these mutations were also described by our center initially. Zach Hunter in our laboratory looking at whole genome sequencing, so that about a quarter of patients with Waldenstrom's have mutations in this center. And then we developed PCRs, assays for this, and that increased our prevalence about 40%. Now, we need to be careful because MYD88 mutations are point mutations, as I showed earlier. Mutations in CXCR4 are also point mutations, but it's less recurrent. So as you can see here in the tail of the carboxyl tail, we can have up to 40 different mutations that can occur in different parts of the gene. Now, if it's true that most mutations are located in 334 and 338, those are the nonsense mutations, there's a lot of other mutations in other locations that are frame shift mutations. Now, we still don't understand very well the biological differences between these or what the impact is on different types of treatments. This is obviously an active area of research in our laboratory. And as you can see here in the table on the right, multiple studies from Europe, Asia, and the United States do show a high prevalence also of these mutations in patients with Waldenstrom's. These mutations are classically subclonal to MYD88. And we will see how these mutations do impact up to some degree the effect of the efficacy of BTK inhibitors in taking care of patients with Waldenstrom's. Now, once we establish a diagnosis, the next step is to understand if we need to treat a patient with Waldenstrom's upon diagnosis. There are many reasons not to treat these patients, mainly if they are asymptomatic. So as of today, Waldenstrom's is an incurable condition. And there's a recent study by the Mayo Clinic in which if you take a patient with asymptomatic Waldenstrom's disease untreated, and these patients have a life expectancy that is very similar to age and sex and race match population in the country. So we are not really prolonging survival by treating patients too early. And now the treatments, even though they're great, and you will see that later, they do have their own toxicities and they can induce resistance. For all those reasons, observing a patient who is asymptomatic is probably the best approach. We have a study on the right, in which was done in conjunction, Dana-Farber in conjunction with other centers. We put together over 400 patients who were asymptomatic at the time of diagnosis. And if you can see the curve, this is the cumulative probability of needing therapy or progressing to need therapy. And we can see that about 30% of patients did need treatment at the 2-year mark. But if you follow this line, about 80% of patients will need treatment within 10 years. This means that about 20%, 1 out of 5 patients who are asymptomatic at diagnosis might not need treatment for longer than a decade. So I think it's an important message so we can monitor our patients who are otherwise asymptomatic. We did develop a specific risk calculator. It's called the AWM calculator, and this can be accessed online. Down here you can see awmrisk.com. And at the time of a bone marrow biopsy, we checked IgM levels, beta-2 microglobulin levels, and albumin levels. And all those data are entered in this website. In this case, I put a 40% infiltration, 3,500 IgM, 2.5 beta-2, and 4 grams of albumin. You click on the Calculate Risk Score tab, and that will give you the patient's risk to need therapy in the future. This patient or a patient with these features will fall within the intermediate or medium category with a median time to progression of 4.8 years. As you can see here in that study, we had patients with low risk, in whom the median time was 9 years, the intermediate risk, and then the high risk, in whom patients have a risk of needing therapy with a median of about 2 years. Now, this does not tell me who needs to be treated, but I can use this data in terms of how frequently I'm going to follow somebody. Patient with low risk, I'm going to follow them every 6 to 12 months, compared to patient with a high risk, whom I'm going to follow maybe every 2 to 3 months. And this is the way I use these data in my practice. Now, obviously, as I said earlier, more than 80% of our patients will need treatment within a decade of diagnosis, and the clinical manifestations of Waldenstrom's are very diverse. And we have cytopenias. Still, anemia is the most common reason to treat patients with Waldenstrom's. And this anemia could be secondary to a bone marrow replacement process, but also abnormalities in iron deficiency, as well as hemolysis, either mediated by warm autoantibodies or cryoglobulins, are also common causes of anemia in patients with Waldenstrom's. Another classic presentation is hyperviscosity. This happens when the IgM goes over 3,000, but more commonly when patients are IgM is over 6,000 milligrams per deciliter. And these patients can present with nosebleeds, headaches, or blurred vision due to retinal bleeds or other processes. These patients need urgent plasmapheresis before initiating a more definitive treatment for the patients with Waldenstrom's. Now, IgM neuropathy is another classic presentation. This neuropathy is very typical. It's distal, sensory, bilateral, symmetrical that progresses over months to years. Some patients can have an anti-MAG antibody mediating this process. We have rarely patients with cold agglutinin syndrome. We have patients with cryoglobulinemia on either systemic light chain amyloidosis. Those are more rare. And obviously, the patient with amyloidosis can present with congestive heart failure, or they can present with nephrotic syndrome, or a type of neuropathy that is more axonal and associated with pain or muscle wasting, and is much more rapidly in terms of progression as well. On the left, we have even more rare complications of Waldenstrom's. We have pleural effusions that can be seen in these patients, and obviously the best way is to get a tab from these. In renal involvement, I want to stop in renal involvement a little bit because I think this is an important differentiation compared to myeloma. In myeloma, we see that over 40 to 50% of patients will have kidney disease, and typically mediated by a process called light chain cast nephropathy. In patients with Waldenstrom's, the renal involvement is actually 2 to 3% biopsy proven based on a series of studies done by us and others. In light chain cast nephropathy is not the most common histology we see. We can see LPL infiltration, we can see monoclonal immunoglobulin deposition. So there are other processes too, and it's much less likely. However, patients with Waldenstrom's also have a very high free light chain levels compared to what we see in myeloma as well. So I do believe that biologically speaking, the free light chains in patients with Waldenstrom's behave differently than in patients with myeloma. And therefore, we cannot use the same slim criteria to recommend treatment in patients with Waldenstrom's. And then finally, rarely we can see this involvement of the brain and the spine by Waldenstrom cells. We call it Bing Neal syndrome. We see it in less than 1% of the patients. Now, once we are ready to treat the patient for the first time, we can actually estimate their prognosis, and we can use the simplified scoring system recently published. It's a group effort led by the Mayo Clinic, but also Dana-Farber and others participated in this study. And we were able to identify age, albumin, and serum LDH levels to estimate numbers of points. Age 66 to 75 is 1 point, over 75 is 2 points. Albumin less than 3.5 is 1 point, and elevated LDH is 2 points. Based on this, we can score patients and divide them into low, intermediate, and high-risk categories. Again, to emphasize, these are collected at the time of active disease when patients are ready to be treated. This is not a diagnosis specifically for patients who are asymptomatic. And depending on the risk, we do have a 5-year overall survival of 93% for low risk, 82% for low intermediate, 69% for intermediate, and 55% for high risk. This is one way of estimating the outcomes of our patients with Waldenstrom's about to begin treatment. Now, the treatment options are very diverse as well. And one of the downsides of Waldenstrom's is it is not like myeloma or CLL, in conditions that are much more common, much more prevalent. And then we have large randomized studies guiding sometimes our course of action and our decisions. In patients with Waldenstrom's, we have, because of the rarity, we do have just very few randomized studies. Most studies are single arm. Some of them are single center studies with small sample sizes, as you can see here. On this table, I'm putting together the rituximab combination regimens that we use more often in the clinic. On the upper side, we have chemotherapy, and that includes cyclophosphamide, fludarabine, bendamustine, but there are other agents. And then we also have, on the bottom, proteasome inhibitors, including bortezomib, carfilzomib, and ixazomib. You can see the sample sizes as the N, anywhere between 40 and 70 patients in most cases, but the responses are very encouraging. The response rates on these prospective studies were ranging between 80 and 90%, major responses between 70 and 90%, and progression-free survivals measured in several months. Now, it's very difficult then to make decisions based on efficacy because all these regimens seems to be almost equally efficacious. So the decision sometimes is made based on the toxicity of these agents. And with chemotherapy, we have to have in mind that these patients might develop a myeloid neoplasm. I think the risk is higher with fludarabine, maybe less with bendamustine and cyclophosphamide. The risk of infections is also important. But the good thing about these regimens is a finite duration regimen, most of them between 4 and 6 months, and patients then obtain a long benefit with that. With proteasome inhibitors, then we have neuropathy, specifically with bortezomib and ixazomib, and carfilzomib can induce some cardiac or pulmonary problems, specifically in elderly population. Now, rituximab infusions are associated with their own problems too, and we can see a very typical IgM flare that can occur in some patients with the first infusion. It happens in about 10 to 30% of the patients, something to be very careful about, specifically if the IgM is high before initiation of therapy. In our practice, we prefer not to expose patients to rituximab when the IgM is higher than 4,000 and delay the initiation of rituximab to cycle 2 or sometimes cycle 3 before introducing rituximab in the system. Unless you are doing a plasmapheresis very early on and the IgM is lower, and then at that time you can initiate rituximab at that moment. We were recommending maintenance based on retrospective data from Dana-Farber and the Mayo Clinic, but this German study, the MAINTAIN study, looked at the prospective evaluation of maintenance. 200 patients got exposed to bendamustine or rituximab, 6 cycles. If they got into a partial response or better, they got randomized to maintenance rituximab every 2 months for 2 years versus observation. And as we can see in this data presented at ASH 2019, progression-free survival and overall survival were no different between these two groups, and therefore maintenance is much less utilized. Now, I want to clarify that these data have not yet been published. Now, moving into a different way of approaching the disease, BTK inhibitors have established themselves over the last 10 years as a standard of care for patients with Waldenstrom's. Now, these all came from understanding the biology and the signaling of MYD88 mutations, in which the creation of the mitosome with the BTK being a central piece of this signaling was important to develop BTK inhibitors. The first study was in relapse refractory patients. We have in the first line on this table, 63 patients were exposed to ibrutinib 420 milligrams all the way to disease progression or unacceptable toxicity. So that's 91% response rate, 73% major response rates, and a PFS rate at 5 years of 54%. So durable, deep responses comparable to what chemotherapy does. Additional data showed high efficacy in treatment-naive patients. And when we add rituximab to ibrutinib in the INNOVATE study, one of the few randomized studies that we have, we saw also very high response rates. Acalabrutinib, we have some data, is not randomized, a single arm for Waldenstrom patients. And then we have zanubrutinib with the ASPEN study, which essentially was a comparison between zanubrutinib and ibrutinib. We'll talk about all that a little bit later. But we can see how the response rates are as high as chemotherapy, the major responses as well, and the progression-free survival can also be measured in several months to a few years, to several years in these patients. Again, the main downside here is that we don't have randomized comparisons between targeted therapies and immunotherapy to guide our decisions. And therefore, we talked about the features of the treatment and allow patients to decide. BTK inhibitors are oral agents, so that's a very easy administration, but they are costly and the treatments are indefinite in duration. So patients could be taking these medications for several years. We do have still patients on ibrutinib from the initial study that we started in 2012. So these are patients crossing the 12-year mark and still responding to ibrutinib. Obviously, the side effects are different, and we do not have neuropathy, we do not have IgM flares, and we don't have the risk of myeloid neoplasms, but we do have the risk of arrhythmias, specifically atrial arrhythmias. Some ventricular arrhythmias very rarely can be seen. We have the risk of bleeding because the addition and degradation of platelets are affected by these agents too. And sometimes we see an increase in blood pressure as well. So a very distinct profile in terms of toxicity. Now, when in the initial study that used ibrutinib monotherapy in patients with previously treated Waldenstrom's, we did see that the mutations did impact the outcomes. Patients who have MYD88 only disease had a deeper responses and better progression-free survival compared to the patients, that's the blue line, compared to patients with CXFR mutations in whom the responses were lower and the median progression-free survival was also shorter, as we can see in the red line. Patients without MYD88 mutations were a minority. Those are more rare, but the responses was even lower and the PFS even shorter. And therefore, we understood, at least in our experience, that patients would respond to ibrutinib differently if they have different genomic profile. Similar exposure experience was in the frontline ibrutinib study, in which the VGPR was 44% for patients without CXFR mutations and 14% for patients with CXFR mutations. And the PFS was also inferior in patients with CXFR mutations. With all these efficacy data, the FDA in the United States approved ibrutinib for the treatment of patients with Waldenstrom's in 2015. In 2018, the results from the INNOVATE study were published, and this is a randomized study comparing ibrutinib plus rituximab versus rituximab plus placebo. And in this study, it was not surprising to see that the response rates were higher in the combination, regardless of the mutation profile, and the progression-free survival was superior for the combination as well. However, one of the downsides of this study is that there was not an ibrutinib plus placebo arm that would have helped to understand what the addition of rituximab brings to the game. And obviously, this is not going to be answered by this study. We did see, however, that CXFR mutations were associated with lower rates of VGPR, 23%, compared to 44% in patients without CXFR mutations. Now, the progression-free survival did not seem to differ much, and this is the red line, especially with MYD88 mutations, and the green line, especially with CXCR4 mutations. So it's a little bit of a difference, but it's not substantial and it's not statistically significant. So there's a possibility that the addition of rituximab might actually benefit patients with CXCR4 mutations. Based on this, the FDA approved actually the combination of ibrutinib and rituximab to treat patients with Waldenstrom's in 2018. And then the Aspen study came around. This was published initially in 2020 and updated recently in 2023. This is a randomization of 100 patients approximately per arm, comparing zanubrutinib versus ibrutinib monotherapy. And this includes patients with previously untreated as well as previously treated Waldenstrom's. In the update, we did see a little bit of a separation on the progression-free survival, numerically favoring zanubrutinib, although this was not statistically significant. And I want to clarify that this was not the main outcome of the study. The main outcome of the study was to show a difference in VGPR, which in this study was no difference. So the study is a negative study based on efficacy. However, as you can see on the right side, zanubrutinib had lower rates of AFib, hypertension, diarrhea, and bleeding compared to ibrutinib. So these safer or more benign safety profile prompted then the approval by the FDA of zanubrutinib for Waldenstrom's in 2021. Specifically for patients with CXCR4 mutations, zanubrutinib induced a higher rate of VGPRs at 21% versus 10%, and the PFS seems to also separate a bit, even though this is not statistically significant. And again, the study was not powered to show a specific difference in these patients, but patients with CXCR4 mutations seem to also benefit up to some degree of zanubrutinib therapy. Now, as we treat patients with BTK inhibitors for years in most cases, and it's reasonable to think that there's going to be an increased cumulative incidence of side effects. And those reductions on BTK inhibitors have become essentially a way to manage those side effects, to keep the patients on a therapy that is otherwise being effective before considering switching to a different treatment. This study was led by Dr. Shena Saroshek from the Dana-Farber, and she put together our experience of over 400 patients with Waldenstrom's treated with ibrutinib. And we noticed that about 96 patients, that's about a quarter of the patients, needed dose reduction on the ibrutinib dose because of side effects. Here in the middle, we can see that the risk of dose reduction was higher in patients who were older than 65, and as well as patients who were women. Now, there's a series of different side effects that we took into account here, and these are separated here on this table. We have, rheumatologic, cardiac, nail, skin, hair changes, GI symptoms, and others. But we did see that overall, and about 2/3 of the patients who had a side effect, the side effect actually improved with dose reductions. Most patients went from 420 to 280. A small minority went to 140, and maybe a couple of patients went down to 70 milligrams once a day. Now, rheumatologic, skin, nail, GI symptoms are more likely to improve, and hypertension are more likely to improve with those reductions compared to arrhythmias themselves or bleeding that are less likely to improve with those reductions. Encouraging data showed that the response was actually maintained or even deepened in more than 80% of the patients in whom the dose was reduced. We have not done an analysis like this for zanubrutinib, but this is ongoing for 2025. Our experience is that it's actually a very similar process as well. Once we are beyond the second line, so we have chemo or BTK inhibitors in the first line, chemo or BTK inhibitors in the second line, then third line beyond, we are using now BCL2 inhibitors. This data was presented published in 2022 in JCO using venetoclax. In this study, venetoclax was given to about 800 milligrams daily and for 2 years. So the VGPR was 19% with a response rate of over 80%. And the progression-free survival was doing really well, close to 80% by the year number 2. And when we stopped therapy, most of the progression events were actually observed. There was a little tail at the end suggesting that maybe 1 in 4 patients might benefit for long term, even though they receive only 2 years of therapy. But most of the bulk of progressions occur between the second and the third year of the study, meaning just 1 year after stopping therapy. So there are ways, I think, to optimize venetoclax therapy. The other agent that has come to the market that of interest in the United States is pirtobrutinib. This is based on the Bruin study. This is data focusing exclusively on the patients who had Waldenstrom's. This data was presented at ASH of 2022 by Leah Palomba from Sloan Kettering. And we did see that in patients with prior exposure to a covalent BTK inhibitor, 67% of those patients did respond with a partial response or better. And about 24% of these patients got into a VGPR or better. So these are really deep responses. A progression-free survival, the median is estimated to be around between 20 and 24 months, so relatively short. And again, maybe an opportunity to optimize pirtobrutinib therapy, but seems to be very well tolerated with lower rates of atrial fibrillation and lower rates of bleeding as well. So in my clinic, once I make a diagnosis of Waldenstrom's, I try to understand if they are truly asymptomatic. In that way, I monitor them and I estimate their time to treatment based on the AWM risk. If the patient is symptomatic or becomes symptomatic during the follow-up, then I estimate the risk of survival with the MSS, and then I start a frontline treatment. In frontline treatment, we have either the chemotherapy agents or the covalent BTK inhibitors. We tend to use either Venda-R most commonly or zanubrutinib. And again, I talk to the patients about the pros and cons of each approach. But I want to clarify too that each and every patient is a candidate for clinical trials. So this is something that we always have in mind. Currently, we have the combination of zanubrutinib and Venda-R, for example, as one of the trials that we are enrolling patients on. If the patient progresses in a first-line treatment, then we get into a second line. And if the patient got chemo, they can get into a BTK inhibitor. If the patient BTK inhibitor, they get into chemotherapy. I think the experience is pretty open in that scenario. But clinical trials are also an option for early relapse. And at this time, we're using pirtobrutinib and venetoclax, for example, for early relapse in our clinic. Now, third line or beyond, we can use venetoclax alone, pirtobrutinib alone. We can use protein inhibitors, even rituximab monotherapy, which is not something we use very often, but in the right patient, with poor performance or has tried multiple trials of treatments, we can always try monotherapy there. And we have also a series of clinical trials in the third line, and that includes bispecific antibodies, that includes antibody-drug conjugates, that includes radioisotopes. So we have maybe CAR T cells in the future as well. So again, I think the message here is multiple treatment options, highly effective, but always participation in clinical trials is key. And that really leads me into the segue of clinical trials, right? I mean, there's a number of trials that are very interesting that I want to talk to you about in a second. So this is the Rainbow study, which has been run in the United Kingdom. And here we have Rebecca Auer, who presented some of this data at the workshop for Waldenstrom's, a couple of weeks ago in Prague. And this is one of the studies comparing actually targeted agents versus chemoimmunotherapy. So this is an important study. 150 participants will be randomized 1-to-1. And the idea is to see, what the difference, if there's any, in the response at 24 weeks and the PFS at 2 years. So this is an ongoing study, and we're really looking forward to see these data, presented and published in the near future. The Germans, led by Dr. Christian Buski, are actually evaluating venetoclax in combination with rituximab compared to chemoimmunotherapy. So this is another targeted agent versus chemotherapy study. This is the VIVA study, aimed to enroll 80 participants and randomizing as well 1-to-1. And the primary outcome is to look at VGPR or better at 12 months after randomization. So another very interesting study being run in Europe. Now, the Canadians are running their own, study combining acalabrutinib, bendamustine, and rituximab in the frontline setting. This is data presented at ASH and will be presented again, an update in 2024 at ASH this year. And what we're seeing with this combination, on the beauty of this combination, is to give 6 cycles of Venda-R, 1 year of acalabrutinib. So triplet, BTK containing, limited duration therapy. And the responses that we're seeing so far are really outstanding. At month 18, we are seeing actually an 86% VGPR rate. So those levels of response are very, very encouraging. You haven't heard me saying complete responses pretty much anywhere in my presentation, is because the CR rate is so low in patients with Waldenstrom's. We cannot even start talking about, minimal residual disease just yet. But I'm hoping that with these newer agents and combinations, we can hopefully get into CRs and start talking about depth deepening of CRs as well. Clover-WAM is actually going to be an oral presentation at ASH this year. This is a radioisotope, iopofosine I-131. 55 patients were enrolled, very heavily pretreated patients. So far, it seems to me that it's an active agent, and I'm looking forward to hear more about this study during ASH this year. The Americans are doing our own, triplets. So we're actually going to use zanubrutinib for 15 months, plus 4 cycles of NDR in previously untreated patients with Waldenstrom's. This effort will be led by Andy Brannigan here at Massachusetts General Hospital. 55 participants looking to a VGPR rate that is going to exceed 70%. In the relapse setting, I'm running the pirtobrutinib venetoclax study. We're actually almost 50% enrolled. I'm going to present a poster at ASH with the initial experience of 16 patients. The goal is to get into a VGPR over 40%, and we are exceeding that VGPR at this time. I really hope you can come by and visit me. I think it's going to be Saturday night that I'm going to be presenting this poster at ASH. My junior colleague, Shena Saroshek, is presenting also at ASH a poster on locastoximab tesirine in previously treated patients with Waldenstrom's. We have about a third enrolled in this study, about 12 patients out of 36. This is a multi-center study run also with the Hutch in Seattle and the Mayo Clinic. This is as part of the Waldenstrom's network, which I will talk about in a second. And Gottfried von Keudel is about to start a phase 2 study evaluating epcoritamab in patients with have received at least 2 lines of therapy for Waldenstrom's. This is also going to be a network study in coordination with the UT Southwestern in Dallas and University of North Carolina. And this brings me to this, the WMNet. The WMNet is a US-based think tank aimed at developing clinical research collaborations in patients with Waldenstrom's. This is an effort that is being led by Dana-Farber. I'm the principal investigator for this effort, and with a critical partnership with the International Waldenstrom Foundation, which is a patient-led organization really focused on educating and researching Waldenstrom's. So we have created this. This was created last year. We have over 20 participants, as you can see, the different participants all over the United States. And the idea is to run clinical trials concurrently, improve accrual, and also access, but also the creation of a data registry to understand the trends of therapy in patients with Waldenstrom's in the United States. And finally, the creation of biorepository to be able to send these samples that were in patients who were in clinical trials into a biorepository for future research. In that way, we can, continue scientifically driving clinical trials in patients with Waldenstrom's. And with that, I really want to finish my presentation and want to thank you for your attention.